Okay, well, without any further ado, I'd like to introduce our keynote speaker, Vincent McCauley. Vincent joined Telstra Health in July 2015 as Chief Medical Officer, advising on areas such as e-health, clinical governance, and pathology. He has vast clinical experience in respiratory and emergency medicine, and he's been a researcher, he's started a company, he has very broad experience. And I was very pleased when he said he's involved in health standards, and it reminded me that one of my colleagues in the US, Ken Rubin, had said, you must meet Vincent McCauley when you get there. And so very happy to run across him in this way. He's the chair of Integrating the Healthcare Enterprise Australia and a member of the IHE International Board. He's also a professor of digital health at Flinders University. He's driven by his goal to create a secure, highly connected and interoperable e-health infrastructure underpinned by sustainable business models. Backstage at the digital health revolution is a messy place, and Vincent's had a ringside seat for the best part of 2 decades. So let's hear from him on the role of digital technology and innovation in health system transformation.
Thanks for that, Wendy. It's a great pleasure to be here today, and I must say that Mary Foley was quite devastated that she was unable to make it, and really only had to make that decision this morning for personal reasons. So real apologies from her, and I hope that I can stand in her place and do it justice. I'm not going to show a slide deck. I'm sure that you will see plenty of those, but I wanted to focus on some of the areas that Telstra Health, where Mary is the CEO, have been looking, and how that may have changed over the last couple of years. Just looking back at where we've come from, it's been a huge journey. When I started medicine in the 1970s, when they discovered that I was also doing computer science at the same time, the level of support from the Faculty of Medicine was underwhelming, to say the least. We've come a long way in that process, so that now digital health is a thing, and it wasn't back then. And that's, you know, only a career ago. So we've made enormous strides to change in that time. One of the things that hasn't changed so much is our ability to translate research into clinical care. I think back to the discovery that bacteria were the primary cause of gastric ulcer by Marshall and Warren in 1982 in Western Australia. In fact, that discovery had been made somewhat earlier, in 1875, when there was the first description of bacteria in the gut wall, in the gastric wall. And in fact, they published a Polish book in the late 1800s, which described those bacteria as the cause of gastric ulcer. But because it was in Polish, it didn't actually see much in the way of take-up. And so it wasn't until Warren and Marshall were able to demonstrate that bacteria were a causative organism and develop a cure for it in the form of antibiotics that became accepted. But it took a long, long time. And I was in clinical practice at that stage, and it was many years later that it was actually accepted by clinicians on the ground that was in fact the case, and the awarding of a Nobel Prize to Marshall and Warren in 2005, before it was actually fully accepted by everybody. So that journey from research to implementation at the clinical care decision point has really been a very big gap, and one that this centre will help to close. And that has certainly been one of the areas that I've been focusing on throughout my journey towards digital health. Mary Foley leads the biggest digital health system developer in the country in the form of Telstra Health. We have over 1,200 employees right across Australia, and software systems that are deployed across all areas of health, from aged care to primary care, hospitals, and increasingly in telehealth. And that company has been a major transforming agent that has really seen the need for these sorts of capabilities to be able to take research and convert it into something that can be built into a digital system and delivered at the point of care. There have been many pressures on our healthcare system in recent times. We've seen a move from acute disease as the commonest issue that we have to deal with to chronic disease becoming a real burden to the healthcare. And most of the presentations are now either have a chronic disease component or are just due to chronic disease. I was at a presentation this morning from Australia's Person of the Year, presenting about the effect of diabetes 2 and how that has transformed and become a major chronic disease right across the world, and certainly in Australia. And we've seen increased demand. West Australian figures came out recently which showed there was a 49% increase in ED attendances over the last decade. We have an ageing population which has led to huge amounts of increased load on the healthcare system. And in association with that, we have an ageing population of carers, many of whom are going to retire in the next 10 years, the baby boom generation. So that ratio of carers to demand is actually falling, and we don't have any way of dealing with that other than through technology. And associated with that, we also have had enormous cost pressures. Technology is expensive. We've seen the costs of MRI and other machines that go pinged. And we've seen how new medications are extremely costly to develop. Some of the medications that have come on the market recently take more than $1 million for a single patient's treatment. And we will see that happen more and more as medications are developed that are truly magic bullets. Some, like the recent treatments for melanoma, which are achieving very effective cure rates, but are very expensive. So those cost pressures have certainly been affecting clinical change and how rapidly we can take that forward. In addition to that, of course, in the last year, we've had the driver of COVID-19. That has led a transformation in our healthcare system from a usual way of caring to remote care and hospital in the home. We've seen virtual care become a norm, and technology that supports that has really taken off. Telstra Health was fortunate in having offerings in all of those areas, and we've seen demand absolutely outstrip anything that we could provide. We've been doubling our capacity in a matter of a few weeks to months to meet that demand, and it has been really phenomenal. We've seen a similar sort of transformation in jurisdictions overseas. In Canada, they introduced telehealth a few years ago, and that led to quite significant transformations in their healthcare system. And so that process that took place over some years in Canada, we've seen take place over a few months in Australia. So that rate of change has been really phenomenal and makes it very difficult for people. People feel uncomfortable with that rate of change, and they're not too sure exactly where they're going to fit in a transformed system. Virtual care has become everything. We've seen virtual care everywhere: hospitals, primary care, aged care, and that will continue, at least in a reduced form, as we go forward. I don't see us going back from virtual care, at least for a substantial part of care delivery. And part of that transformation and rush to get things done that we were struggling to get done before has been things like e-scripts, where a process that was anticipated to be completed by the end of 2022 was completed in a couple of months by the middle of this year. So we've had things that have been ready, but needed a big push to get them out there and available, and COVID has provided that. May not have been comfortable, but it's certainly been effective. Unfortunately, COVID's highlighted issues in our workforce, particularly in aged care, but as we've seen in Victoria, the rate of infection of our healthcare staff has been very concerning. So we've got some work to do in those areas, and I think we're adapting and learning very quickly from those challenges. One of the things that's been helping with that has been the formation of the National Cabinet, which has been quite effective in overcoming fragmentation and introducing national thinking, at least in most jurisdictions. The real challenge is, how do we maintain the momentum that has been pushed forward by COVID and other pressures? One of the big contributors to that is going to be creating accessible, high quality data. That data has to be based on standards. Standards have been one of the things that I've worked on for more than 2 decades, both in Australia and internationally. And those standards are now effective, ready, and they have, in many areas, shown what a big change they can make. We need to use them more widely and make them, in some areas, mandatory. Associated with standards, we need common terminology. And again, we've taken big strides in that. We now have a national clinical terminology service, and many of the health software companies, such as Telstra Health, are also rolling out their own terminology services that mean we have consistent, accessible, shareable, interoperable clinical terminology like SNOMED and LOIC. And that interoperability of systems has to be achieved through a high level of governance that oversights how those systems work, and also how things are taken forward when they don't work. How do we deal with system failures, which will inevitably occur? The more complex system we build, the more things there are to go wrong, and we need processes to be able to detect that and fix them. And what will having accessible, high quality data do for us? Well, it will enable predictive analytics and AI. Things like predicting deterioration of patients before they actually deteriorate. Things like making clinical information right across the sector from all points of care available at the point of care that's being delivered to a patient at that time. I think back to my times in the emergency department at Royal Prince Alfred Hospital on a Friday night, being posed with a patient that's come in and been attending the hospital on a weekly basis for the last 5 years with a chronic disease, who I've never seen before, who I believe has a stack of notes that's at least 10 metres high, but which none are available because they're locked up in the outpatients department where they were the day before. So you're faced with getting a 5-year clinical history from a sick patient to institute immediate care with very little knowledge about exactly what the problem is and what's been happening to them. That is no longer the case. In the vast majority of our care situations, we now do have at least some clinical data, and moving to a higher degree of that clinical data and higher quality will effectively enhance patient care. And we're developing the new care models, telehealth, hospital in the home, remote monitoring. They will both reduce our costs and also improve patient care by having a more global view of patient information. We've developed some really smart systems. We're going to hear about SafeScript, delivered by Telstra Health partner and partially owned Fred IT. And we've been really pushing SafeScript as the president of the Medical Software Industry Association. Some 10 years ago, we first developed the idea of SafeScript in combination with the federal and state governments, and it's taken a long time to get out there, but it's proven a very effective system. And I'm pleased to hear that you're going to hear about that from the DHHS. The National Cancer Surveillance Register has proved very effective, 3 years in the making, difficult incubation, but now a world first. And we've actually been looking around at other world areas, and we're seen to be the leader in this area. The UK is now, having decided that there was nothing available in this area that they could use and were going to build it themselves, are now looking at our National Cancer Surveillance Register as an option or as a model for them to take forward. So we've got some really world-leading platforms that we can build upon and use effectively for patient care. And we're in the process, the whole of the software industry, of replying to a federal government tender for management of infectious diseases on a national basis. Again, obviously the focus has been COVID-19, but this will prove really valuable as other pandemics come to the fore, as I'm sure they will over time. And decision making we've seen move from the IT department to CEOs and chief medical officers and chief nursing officers. And that's been a really valuable change in that now we are seeing systems being deployed that are immediately applicable to clinical situations and which clinicians feel safe and can see immediately how effective they are. And tech is being used to marshal research for clinical care. We've seen a number of initiatives in this area. Wendy mentioned Ken Rubin's work that's been happening on an international basis. It's called BPM+. It looks at empowering clinicians to be actually able to develop clinical systems that integrate with our existing EMRs and other infrastructure. And we've launched a process in Telstra Health to look at how we can bring that to the marketplace in the near future. But being able to shorten that time frame from clinical research to clinical implementation is really the focus of that transition. And it's that transformation potential that digital health offers that this centre will promote and launch. It will provide a way of focusing industry on the high value tech changes and not be distracted by those that are sexy or in some way, technically interesting, but actually don't deliver the clinical benefits that we are looking for. And also inform policy and budget, which is really important. As a coalface clinician, I did not realise the importance of that other than treating the Federal Minister for Health at the time. But it's only been in the last 5 years in my position at Telstra Health that I've begun to fully understand how being able to inform policy and understand the impact of budgetary constraints actually is an important driver in taking us down paths that produce really good results for clinicians. The centre will encourage collaboration by diverse institutions, and there are a number of others already in place in Australia that will absolutely merge or will be able to mesh with this new centre, and together they will be stronger, more effective, and able to deliver great outcomes. So I'm really looking forward to another leap forward in the transformation of health into the digital arena. Thank you, Wendy.
Thank you, Vincent. That was fabulous and amazing that you could pull that off with such short notice. Our next speaker is Rinaldo Bellomo. He directs the Data Analytics Research and Evaluation Center at Austin Health and the University of Melbourne. And his center goes by the short name of DARE. And any of you who don't know Rinaldo, when you hear him talk, you will think that that acronym fits him and his group perfectly. He's the Director of Intensive Care Research at the Austin Hospital and Professor of Intensive Care Medicine at University of Melbourne. And he's also the co-director of the Australian and New Zealand Intensive Care Research Centre and an NHMRC Practitioner Fellow. He's on a lot of lists. Since 2006, he's been the most published intensive care investigator in the world. In 2014, Thomson Reuters recognized him as one of the most influential scientific minds in clinical medicine. And he's the most published biomedical investigator in the history of Australian medicine. So we're just so lucky to have him tonight and looking forward to his talk. He's going to be speaking on the evolution of our ability to use electronic medical records in acute care.
Thank you very much, Wendy. I look forward to presenting about DARE, which hopefully the slides will appear soon. We were lucky enough about 2 years and a bit ago to be supported by Keynote and the university to start exploring the ability to use electronic medical records in acute care to evolve our ability to understand disease and inform treatment. We were supported to form a small group of investigators, which were clinicians and data scientists, to see if we were able to evolve our ability to use the data that is produced in electronic medical records within a hospital system, such as the Austin Hospital, to inform future investigations in the field elsewhere. We got going and we tried to focus on at least 3 major areas of investigation, which related to sepsis, delirium, and the facilitation of randomized controlled trials. We focused, first of all, on trying to understand if there were better ways of identifying septic patients that were at particular risk when presenting to the emergency department using a tool called the Q-SOFA. Why would we do that? I was lucky enough to be part of the 3rd International Consensus for the definition of sepsis and septic shock, or sepsis 3, which identified that in people presenting to hospital with infection, the assessment of the respiratory rate, the blood pressure, and the conscious state, so-called Q-SOFA, quick sequential organ failure assessment, might be helpful in identifying those very patients that need to have advanced care or are at risk of doing badly. So we wanted to see if the EMR of our hospital would enable us to identify such patients. And you can see there that using the EMR, you can identify all the adult ED presentations, 165,000. You can identify those suspected infection by linking the admissions to the ordering of microbiological tests, as well as the administration of antibiotics. And you can identify that 20% of these patients were Q-SOFA positive. It can identify that these patients had almost a 13% mortality. That has to be put in the context that if you present to the hospital with an acute myocardial infarction with ST segment elevation, your mortality at the Austin is about 5 to 6%. So clearly a very high risk population. And this now has created the ability to develop alerts for clinicians in the emergency department that can tell them that there is a patient that fulfills these criteria in the emergency department and can hopefully change the rapidity, the context, and the efficacy of care. And the currently advanced process of delivering such alerts is holding out for COVID to finish so that we can actually move to a more normal world and we can implement such alerts. Identifying people with delirium is a very difficult thing to do because there is no standard definition or gold standard that says that somebody is or is not delirious. We define that somebody is such in language. We use words like confused, agitated, disorientated, aggressive, combative. And these words can give us a window on the presence or absence of delirium in ICU patients. We can use the EMR notes entered by nurses, residents, registrars, physiotherapists to analyze whether patients with delirium are present and how many there are and what their characteristics might be if we can identify them by such means. So this is reading 60 million words, thousands of EMR notes, and you can identify over a period of several years and 12,000 patients admitted to the Austin ICU that about 5,000 of them are characterized by notes written by nurses and doctors that identify that they are disorientated, confused, agitated, and so on. The identification of these patients then opens the door not only to alerts, but also to important epidemiological assessment of what medications can or cannot do for these patients. Doing trials is a really expensive business. Randomizing large groups of patients is a very costly undertaking. We wanted to see if doing EMR leveraged randomized controlled trials would allow us to randomize thousands of patients, a large group of patients, and achieve high quality data capture at minimal cost. This is a paper we recently published in the Journal of the American Medical Association. It is one of the biggest randomized controlled trials in anesthesia, and tried to test whether the large tidal volume that is typically given to patients during anesthesia is necessary or it is actually potentially detrimental. The study was conducted at the Austin Hospital, and it's a study that in terms of numbers randomized would typically cost $3 to $4 million in Australia and New Zealand, and more than $10 million in the USA. But we did it, and it cost $35 per patient randomized. And it's been published in one of the top journals in the world, and it was able to identify that there is no advantage of using high tidal volumes. And in fact, there was a trend in the other direction, particularly for laparoscopic surgery. Such large tidal volumes may be injurious. So let me conclude by saying that the DARE experiment has delivered multiple lessons, insights, and has opened the door to interventions. We're now incredibly busy dealing with multiple trials and multiple activities, and we've got more EMR-based trials coming along. We have contributed and are affiliated to the publication of more than 30 papers, about a paper a month since we were created. And I would like to say that it's been a wonderful experience to work with data scientists and discover that if you've got a clinician alone, you don't produce anything like what you could with a data scientist. If you're a data scientist alone, you cannot have the domain knowledge to deliver clinical science. But in DARE, by putting them together, we've had a new maths of 0 plus 0, delivering 30 papers over 2 years. Thank you very much.
Thank you, Rinaldo. So now those of you who haven't met Rinaldo before know firsthand he's a force to be reckoned with. And we hope through the center that we're able to learn from what they've done with DARE and build a similar kind of environment so that other hospitals and services can have similar experiences. Our next speaker is Melissa Skilbeck. She's the Deputy Secretary of the Victorian Department of Health and Human Services. Given she heads up the department's Regulation, Health Protection and Emergency Management Division, it's safe to say she's had a very busy year. There's a strong public health theme in her work, which includes identifying risks and social regulation to influence behaviors. Recent achievements in her division include the highest 5-year-old immunization schedule coverage in Australia and real-time health emergency monitoring of numbers of patients arriving at the EDs across the state. We're very pleased to have Melissa speaking today about the development of SafeScript, a real-time prescription monitoring system that has been a long time in the making, but launched broadly in 2019. SafeScript provides prescribers and pharmacists with a clinical tool to make safer decisions about prescribing or dispensing high-risk medicines, and facilitates early identification, treatment, and support for patients who are developing signs of dependence. And the reason we were really interested in having her talk about this is it's a system that's connected across the whole nation of Australia. And it was a lot of effort to get that into place, and it's been fully embraced. And so we'd like to learn from her about how she did it and how that whole group did it.
Thank you very much. And can I extend my congratulations to everyone involved in the establishment of the centre. I couldn't agree more with the need for digital to join with health for better outcomes. And that was a key driver here. Hopefully, if Liz can put up the slides, we'll be showing you what drove us to SafeScript. Dr. McCauley noted a decade ago number of people driving for a SafeScript system, and indeed the Council of Australian Governments had made a decision to do it a little bit less than 10 years ago. Yet it took quite a bit longer than that. If I go to the slide, deaths in Victoria sadly drove us. So the classic comparison to give a sense of proportion is deaths from prescription medicine vis-a-vis road fatalities in the state of Victoria, and that was the very significant increase in the mauve bar there of deaths due to prescription medicine. So the Victorian coroner was making a lot of commentary around that, as was, and directly to our department and ministers, as was some more personal advocacy. If the next slide shows you a picture of the Millington family. John and Margaret Millington is there with their son, Simon. He became addicted to prescription medication following a car accident. And very sadly, he died in 2010. His parents have been extraordinary in their campaigning for a real-time prescription monitoring system. They have assisted us enormously throughout the journey. And I was just talking to the team today about giving them an update on some happy news that had occurred from New South Wales yesterday, which I'll get to. They had a working example and the passion behind the impact of people seeking additional prescription medicine from multiple prescribers, in the particular case of their son, across state lines. The system was hoped for to give prescribers and pharmacists real-time data about a patient's history of high-risk medicines like benzodiazepines and oxycodone and others, so that they could better coordinate care and prevent multiple prescribers prescribing the same medicine unknowingly, and reducing that to reduce the risk of harm. As I said, many others, in addition to the Millingtons, being clear about that. For us, we did a lot of pre-work before we got an approval from the Victorian government in 2016, where we got a budget commitment of 29.5 million over 4 years, and the 4 years to do the project. But if you look to the next slide, we could not do this alone, and I just note there the extraordinary array of individual organisations who assisted us along the way in various ways, but particularly through expert advice all the way through. It was a co-designed system. I mean, we did not always agree entirely, and there were different factors in some degree of detailed implementation, but very, very clear message from practitioners and from medical digital software providers, PHNs, etc., that the information needed to be genuinely real time, that importantly it shouldn't interrupt clinician workflows. And there was an array of different workplaces that clinicians were in, and that meant different things, but it meant that we were in the space of engaging with the pre-existing practice software in a number of workplaces and professions, and that health practitioners needed support to interpret and act appropriately on the information they received. That foremost, this needed to be a tool that supported better clinical advice and treatment. As Dr. McCauley noted, we partnered with Fred IT largely to design the technology on which this program is based. We also had support from Microsoft and from AHPRA, the Australian Health Practitioner Regulatory Agency, who gave us access to confirm registered practitioners for access to the system, and also supported our education and delivery around the system. I'm going to show you a slide that I suspect many of you have vastly more technical background to understand. But in effect, this illustrates the project. The platform is based on real-time data, and that is, it's based through the prescription exchange services, which Fred IT had a significant experience and expertise. This meant that our background information is continually updating in the. It also meant the prescribers didn't need to click in and out of systems. We integrated SafeScript with the multiple key platforms for prescribing and dispensing. We held a lot of test sessions with users, different sorts of practitioners in different environments, to get feedback on both design and usability, because that interface was fundamental to the effectiveness of SafeScript as a tool supporting clinical treatment. And a great number of people assisted to do that. The other element of support was online training, which is the next slide. Both online and face-to-face, once we could do that, a significant amount of work that is ongoing to support clinicians on how to best respond to this new information that SafeScript provides. And it provides information On the screen, you'll see in the corner there that gives a degree of warning or a green light to the intended additional prescription that a doctor might put forward, or the dispensing event. But on the basis of a number of algorithms that go to combinations of drugs or sheer volume of morphine equivalent that might present risk as advised to us by a clinical group that we're regularly testing that listing of risky combinations of drugs with. We rolled out SafeScript initially in Victoria in October of 2018, initially for a trial period, and then on a voluntary basis for practitioners. On the 1st of April this year, it became mandatory for prescribers and pharmacists to use the system under state law. The pop-ups that you see have been responded to now for all of this year. We're starting to see some outcomes. It was, though, a point of some debate between the expert group I noted before and ourselves. Clinical experts were wanting more alerts rather than less. A lot of the advice we received from behavioural insights folk, those who do the nudging in policy world, were very clear about alert fatigue. So that's a balancing act we're still testing as we go and keep active maintenance of the system. The sorts of drug or dose combinations that trigger a red alert there have triggered, in the last 6 months, it's triggered about 2.3 million alerts. So there is a significant amount of alerting going into practitioners. There is additional information, and the question then becomes, has it been worthwhile? What's the worth of what we've done? We go on to the next slide, as we've attempted to test this in a number of ways. We believe the SafeScript system has already proven its worth and did so in its first weeks of operation. It was not only rare that a system was delivered on time and to budget in the manner in which we did with such a genesis as it had, but importantly, on a policy basis, it certainly proved its worth. You'll see a little map there that Victoria developed SafeScript separately from the national system that was previously being pursued, and we were previously pursuing, because of the significant advances in technology meant that there was a much better option available through the exchanges. But of course, from a policy position, one state having a system and not the neighbouring states across the borders, to hark back to the Millingtons experience, but it was not going to be successful unless it was national. So it's with a great amount of pleasure and pride that we look at that map and see that almost all of our fellow subnational jurisdictions are now on board. The additional bit of information we have from yesterday is the New South Wales state budget has provided our colleagues with some funding to implement their version, the SafeScript national platform as well. So that's a very significant gain. We have, albeit the system is mandatory, nevertheless, there's always a question as to how many practitioners are both registered and using the system. We know that we have over 87% of GPs, 82% of pharmacists, and around 60% of nurse practitioners of those who are registered, and some of those are non-practicing, the total registrations, are on the system and using it. Then we go to trying to establish whether we've had an impact on harm to those taking prescription medicine. We've seen a downward trend on people seeing 4 or more prescribers, which is something of a leading indicator. We have also seen a significant, a reduction in the number of deaths from prescription medicine overdoses. This information in the bottom corner there has only just come out from the Victorian Coroner's Office. And while a small decrease from 2018 to 2019 of 424 deaths to 405 might seem relatively small, it's the first time we've seen any reduction in a decade. The Coroner's Court noted SafeScript along with some excellent clinical resources that the Australian College of General Practitioners had introduced as well, and I'm sure there are other influences. Attribution is awfully difficult. But we take those signs and our own interventions, looking at the data ourselves to get in contact with practitioners when we see things, to be confident that this has had a very significant impact on public health already. We look forward to a much more significant impact across the nation as this becomes a genuinely national platform. And hopefully it's another example of why digital health is so important. Thank you.
Thank you so much, Melissa. Our final speaker is Christine Kilpatrick. She's been the Chief Executive of Melbourne Health since 2017. And before that, she was at the Royal Children's Hospital and in various other roles. She is a neurologist specializing in epilepsy. Christine's a member of several boards, including Origin, National Center of Excellence in Youth Mental Health, the Walter and Eliza Hall Institute, and the Florey Institute of Neuroscience and Mental Health and Victorian Comprehensive Cancer Center. So she's a very influential person in our state. Christine's led the introduction of the electronic medical records in 2 hospitals, starting with the Royal Children's and now Royal Melbourne. And they went live at Royal Melbourne during the pandemic. They were slated to go live at the very beginning of the pandemic and postponed it and ended up going live during the pandemic. So it'll be very interesting to hear from her about how that went. I'm sure there are some unanticipated consequences and local quirks, but we know from hearsay that it's been a success and that it's a crucial element in designing a more patient-centered journey. So to tell us about this journey and what's on the horizon, let's welcome Christine.
Thank you very much, Wendy. I think someone is going to put up some slides. Thank you. So what I'm going to talk about briefly is the introduction of EMR in Parkville, in particular across the Parkville or Melbourne Biomedical Precinct. Get the next slide. So the Royal Melbourne Hospital, where I have the privilege of being the Chief Executive over the past 3.5 years, but we have a strategic purpose, which is about advancing health for everyone every day. And to deliver this, we've identified 5 strategic goals, and 4 of these, the EMR, electronic medical record, is absolutely fundamental to achieve. Those being that we want our organisation to be a great place to work and a great place to receive care. We want to grow our home first, our home-based program. We want to realise the potential of the Melbourne Biomedical Precinct, and so in particular the connectivity of the 4 hospitals in the precinct. And of course, we want to become fundamentally a digital health service. Next slide. And so it's fair to say that the health sector has been rather slow to use technology to support and to deliver healthcare and really to implement an enterprise-wide electronic medical record. And I think there are a number of reasons why that's so in this country. I think our sector is somewhat risk-averse. Health has traditionally been risk-averse, and probably government, for some good reasons, has been risk-averse. We've seen plenty of technology implementations fail, and early attempts, in particular in Victoria, to introduce digital health systems were not particularly successful, overall weren't successful. So this added to, I guess, the negativity and reluctance to go down this pathway. And then the final point is that obviously it's an expensive endeavour to implement, and cost meant we needed government support to achieve this. Next slide. So it became obvious to us that Healthcare is really, I think, is far too complex these days to be managed on a paper-based system. It just is far too complicated. And the benefits of an EMR are very clear to us all now. They support safe care, reduce variation in care, reduce duplication of care, assist in doing the right thing and delivering evidence-based medicine. They improve connectivity of care across the precinct, particularly when 4 hospitals are on the one system, and they improve the patient experience, as well as, of course, the fundamental ability for the patients to have access to their own medical record. And, of course, very, very importantly to us and to the university and to our medical research institutes is that they enhance research across the Melbourne Biomedical Precinct. So we knew very clearly in our minds that what we needed was an electronic medical record. And next slide, in 2018, we were fortunate that we were able to convince the Victorian government and they were committed to funding the implementation of what turned out to be our choice EPIC system across Royal Melbourne Hospital, Royal Women's Hospital and Peter MacCallum Cancer Centre, using the Royal Children's Hospital EPIC instance, which we had implemented there and went live in 2016. So next slide. So we called this program, it was a big program, it started in 2018 and as you heard, we went live in August this year, and it was we called it Connecting Care, because that's what it's all about. And these are the logos of the 4 hospitals. So it was a big undertaking, but a big cultural change for all 4 organisations working closely together, but we did successfully do this. Next slide. And so I think there are a number of factors which are critical to the success. I mean, I've the experience of doing only 2, I must admit, but nonetheless, there's probably not that many CEOs who've put in 2 electronic medical records, but or been involved in it, I should say. So critical to success are these factors, I think, is you need to get a project director who's done it before, at least once, preferably a few more times than once. So on the precinct here, we recruited Jackie McLeod from the Children's, so put it in at the Children's, and she'd also put in a Cerner at Austin, so had a vast experience of both Cerner and EPIC. So that was a great success factor for us. The other is the choice of the product. When we're at the Children's, we went out to tender and EPIC was our choice. And they have certainly been a good company to work with. You work hand in hand with them. And they're as keen to have success as we were keen to have success. So we both needed to succeed to be a successful outcome. The other is, I think, fundamental is to see the EMR as not an IT project. Although IT is critical, of course, and IT staff are critical to support it, it must be seen as a change management, a clinical change management project. And I learned that very clearly at the Children's. The other is, of course, engagement of clinicians, not only in the implementation, in building it and working with us, but also in the choice of the product. And at the Children's, we had them on the procurement team and choosing which product they wanted to implement. I think it's key to focus on change management because that's what it's all about, and so significant resources for change management are critical. The governance of the project is really, really important. We had all sorts of layers of governance. Sometimes think maybe we overdid it, but it worked well at the Children's, so we used the same model for the precinct, and I think it has served us very well. And the other point is we had a team of 120 and at one stage 150 people working to build the EMR, and 64% of those people came from the health services, including the Royal Children's Hospital. So there's a lot of people understood what they wanted to achieve, understood the health services, and now when many of those go back to their roles, original roles, then they take with them extraordinary amount of knowledge. And similarly for super users, which are critical to a successful go live, these are the people who are trained up and know everything imaginable about the EMR system. We used in-house people. So we looked for our own clinicians to become super users. We didn't bring super users from outside. So that certainly worked very well. We also used medical students who worked out to be wonderful super users as well. And I think they very much enjoyed it. So the project, just at a high level, went across 25 sites of Royal Melbourne Hospital, so it's huge. 5 sites for the Royal Women's Hospital and 5 sites Peter MacCallum Cancer Centre. and 11,900 odd staff needed to be trained across our organisations. And as you heard, we were planning to go live, and we're on track to go live. The date was chosen some time ago for the 2nd of May this year, and we were on time, on budget and in scope, but COVID wave 1 arrived, and at the end of March we were hearing stories that there'll be a big and serious wave 1, and no doubt if that is similar to what we'd seen overseas, and 40% of staff would either have COVID and not be at work, they'd be too afraid to be at work, or they'd be furloughed. So we made a terrible, when I say terrible, a very tough decision, but there was enormous pressure on us to defer and say, no, we will not go live because of COVID wave 1. Well, by the end of April, COVID wave 1 was disappearing, and we thought we'd dodged a bullet and we would be fine. And so we made a further decision. Yes, we would go live, and we chose the date of the 8th of August, 2020. And the reason why it had to be quite a few months ahead is that because of all the social distancing, we had to change our model of training. We couldn't have lots of people in a room, which we normally would do. We had to have very few people socially distanced in a room, and we needed to do online training as well. So that was our date we chose for the 8th of August. And the next slide, you'll see that was absolutely spot on. Our peak of COVID patients, inpatients at Royal Melbourne Hospital. In fact, it was 4 days earlier at 99 we had, but it was about 94 patients we had on our go live date. So it was a very difficult July and early August coming up, and wondering whether we should keep going. Of course, there are a number of staff who thought we should definitely stop, but there's an enormous amount to lose if we stopped, and an enormous amount to gain by going live. And so very nervously, very anxiously, we decided that we keep going and we would go live. And the next slide, I think, it talks about, I'm highlighting here the benefits of the COVID, of going live, not going live in a pandemic, but having an electronic medical record in a COVID pandemic and in beyond. And the first point to make is that the go live was remarkably, surprisingly successful. And I think staff saw it as a distraction, sounds odd, but a real distraction from what they were going through with looking after COVID patients. So, and managing the situation. So that was a positive. But the other positives, that once we had the EMR, we could manage the screening clinics, which we had here at the hospital, for patients who came to be screened and be swabbed, and screening of visitors who came into the hospital. And the questions, as you may all recall, kept changing all the time. And so this could be quickly and automatically updated into the EMR. And that happened very frequently and was so much easier. And guidance for PPE could be quickly and frequently uploaded into the EMR, and we could keep up to date. We could understand the COVID status of our patients. We had automatic reports on the number of patients in hospital who were COVID positive, who were suspected COVID, and who had become cleared of COVID, and their location. And that was just automatic. Whereas before that, we were having bits of paper trying to work out where everybody was. The other very important issue that I never thought about as being a positive of an electronic medical record was that staff were able to access the medical record either from their home, if they were at home, or from another site, or away from the patient. And this was, of course, an enormous benefit with social distancing during these times. The other is that we could use telehealth, and staff could be at home and use the EMR to do telehealth and enter into the medical record. They could be at home and look at the patient's record when they're an inpatient in the hospital and see what was happening. We also realise now, we never thought of this as a potential benefit of the EMR, is that this can be we can support our home-based care. And so we're now starting to use the EMR for supporting patients at home, and this is a great asset for our staff. And then finally, of course, virtual care. There are a number of ways of supporting patients out in the community, and the EMR is a huge benefit for that. So I guess we've always seen the benefits of the the safety of care and understanding the patients and understanding what the flow of patients and having everything at your fingertips and the benefits for research, and they are of course profound. But we had never thought through or thought about these benefits such as telehealth and home-based care and virtual care, which has clearly come from the EMR. So that's been our journey, where, you know, there are all sorts of, I make it sound like it was absolute roses. There, of course, were some challenges with the go live, but overall it's been remarkably and surprisingly successful. And I think in a funny, strange way, the COVID pandemic probably helped us along the way. So thank you, Wendy.
Thank you, Christine. It was wonderful to hear about that journey.